welcome everyone. I'm Megan from the Pituitary Foundation. So before we begin our session this evening, we do have a few bits of housekeeping. So we have enabled closed captions. So if you'd like them, just click the CC button at the bottom. And for those of you not familiar with the Pituitary Foundation, we provide support to the 70,000 plus people in the UK who are affected by disorders of the pituitary gland, as well as their families, friends and carers. So we want to ensure that every person affected by a pituitary condition has a timely diagnosis and access to high quality treatment, information and support. We have a dedicated nurse helpline, online and printable resources, and we work with leading medical experts to improve patient care. So I'm really excited to be having this talk as part of our Pituitary Awareness Month programme. We've had lots of events already this month and a few more coming up, so please do sign up for those if you haven't already. For people who are not using visuals this evening, I am a young, mid-20s, just white woman with blonde hair. I've got a skin colour top on, lilac dungarees, and my hair is kind of fading into my blurred background. This session will be recorded and will be on our website later in the year. So no one's faces or comments will be visible unless you want to ask a question or have your camera on. We want to ensure all of our events are welcoming and accessible for all, especially as we may explore personal experiences in this session. To this end, please can you remain on mute when not talking to manage background noise. And you don't need to have your camera on if you prefer not to, but it's always lovely to see those who feel comfortable to. You may also wish to add your pronouns to your name, as you can see I've done here, just so we know how you can refer to you. To chat at the end, we will have a bit of a Q&A, so please use the chat bar, and Dan, I think, will be reading out your questions, but we will get to all of them. Please be respectful as people share their personal views and experiences. The session will finish around 8:30, so thank you very much for joining us for this evening session. And please do feel free to leave early if you need to, it's absolutely no problem. Right, well, that's everything from me. So thank you again. I'm going to hand over to our brilliant speakers for this evening. We've got Dan and Rob. So Dan is going to do a bit of an intro first. So over to you.
Thank you very much, Megan. Good evening, everybody, and welcome to what promises to be a really exciting evening about everyone's favourite subject, acromegaly. First of all, just want to say a huge thank you and well done to the Pituitary Foundation for putting these events on. It's very important and it's very useful to the community, not only to try and raise sort of wider awareness, but to help and support people wherever they are on their journey. And that's something that we'll talk about a little bit later on. We'll do a quick survey, not right now, but after Rob's presentation, where people are at on their journey. Are you recently diagnosed? Are you in remission? Let's see where people are, because that will help sort of help shape the flow of the discussion. We'll probably talk about my journey a little bit later on as well, after Rob's presentation. But I know you're all here to see Rob. So Rob is a consultant endocrinologist and honorary associate professor at Leeds Teaching Hospital, NHS Trust. And I couldn't really find any more information about Rob, if I'm perfectly honest, online. But I did search his name, and I did find numerous articles or reports, documents that Rob has written over time that have been cited by other people, which is always a really good sign. So just a couple of examples of these titles: a critical analysis of clinically available somatostatin analog formulations for therapy of acromegaly. Adults with partial growth hormone deficiency have an adverse body composition. The list is huge. So we know we're in really good hands. Rob's going to talk us through, I think, the whole journey of acromegaly, looking at treatment, long-term implications, and then we'll see where the discussion flows after that. So Rob, thank you very much for your time. Over to you.
Okay, thanks, Dan, and thanks again to the Pituitary Foundation for this session, because I think it will hopefully will help people understand a bit more about this. And then I think the questions afterwards pertaining to people's own journeys obviously are going to be really important. So I will start with the this and see if we can get it to work with my great IT skills. Oops, I forgot to push the, did I do the share screen thing? Share this one. I think it's working.
Yeah, it's looking good. Just go full screen and you're good to go. There we go.
Perfect. Good. Okay, so we'll go through it from the basics and work through complications of acromegaly, and then through some of the things I think that are problems for people who've had disease for a long time and even in remission. So acromegaly is essentially, it's the clinical consequence that we see of people being exposed to high growth hormone levels and high IGF-1 for a prolonged period of time. And it takes a long time to make those tissue changes. IGF-1 is the second messenger. So like all hormones that come out of the pituitary, they act on tissues and they make a second messenger. So similar to the thyroid, TSH, when the pituitary acts on your thyroid and you make thyroid hormones. So growth hormone acts on peripheral tissues and you make IGF-1. So they're both markers of how much growth hormone a person makes. So acromegaly is a pretty rare disease. It's 4 to 6 cases per million of the population each year. So new cases, so not a lot. And on the background, fairly wide looking across populations across the world, somewhere between 28 and 137. Most of the UK data comes around 60 to 65 cases per million. So we're talking probably 3,500 to 4,000 cases of acromegaly in the UK. So it's not a common disease. And you can put that in context by the fact that I've since been in Leeds, have seen about 2,000 people who have had thyroid disease just from a local population. So most commonly acromegaly presents at the age of 40 to 50 years, but it can happen at any age. It's equally prevalent in males and females, and pretty much always due to a pituitary adenoma. You can get rare carcinoid tumours either in the lungs or the pancreas that produce growth hormone, secreting hormone that then stimulate the pituitary to make growth hormone. So they can happen. The majority of pituitary tumours that give people acromegaly are large tumours, well over 1 centimetre in size. So more troublesome because of that. And there's a genetic predisposition in some tumours. Most are sporadic and have no genetics, but there's a few that do, and you're more likely to have a genetic predisposition if you get disease when you're younger. How do we pick this up? Well, pretty much we're still relying on finding people with acromegaly within the population by their visual appearance, and this is how people are picked up. So there's that overgrowth of the jaw, the overbite, the dental separation, the thickening of the lips, widening of the nasal bridge, this supraorbital ridge, that's that bit across the top of your eyes, becomes more prominent, a bit more furrowing of the forehead and coarsening of the facial features. And then there's that large hands and feet that are associated with this. We see a lot of people have had rings cut off because their hands have got too big. A lot of people have changed 2 or 3 shoe sizes as a result of this, but haven't particularly questioned why that's happened, surprisingly. If you get it when you're young, you get all those features, but also if you haven't stopped growing, we can potentiate to make you grow a lot more. Yeah, and that's what gigantism is. Only get that if you haven't finished growth. And symptoms-wise, these are what we find out really once we've already visualized and realized someone has acromegaly. These are the kind of things we ask people. And headaches, lethargy, and sweating are probably the top 3 up there of symptoms that people complain of. There's a bit of joint pain, that change in the voice, thick and oily skin. Vision, if the tumour hits the optic nerve, the vision's impaired, often snoring as a result of sleep apnea. And then there can be a whole bunch of other symptoms which relate more to the large pituitary tumour damaging your other hormones that the pituitary makes. So none of those symptoms really particularly specific. So it's how we pick it up really is on the visual appearance. And that's possibly why, being a rare disease and that it takes a long time to change the soft tissues, is why these cases of acromegaly are probably picked up quite late. We pick them up for a wide spectrum of healthcare. So I've had a couple of people with jaw pain referred from the dental school. We pick people up on the ward who've just been noted. They come in for other operations like spinal operations, which we picked up. I had a gentleman who a doctor thought he might have on a night out, thought he might have acromegaly, and left a note for him the following morning to go and see his GP. So we get a wide spectrum of how they're referred through to us. It's an insidious onset, as mentioned. So often most people have had this disease 8 to 10 years by the time they come to our attention. One of the ways we could make this easier and pick people up earlier is population screening. And we tried screening the sleep apnea clinic and spent a lot of time screening 1,000 people with sleep apnea to see if we could pick up people with acromegaly earlier. But after spending a lot of time, a lot of money on assays, we found one person. So it's probably never going to happen. Complications. This is one of the important bits about acromegaly. Above the somatic changes and the changes in features is the complications. So having acromegaly means you're much more likely to get diabetes, high blood pressure. Cardiomyopathy means the heart doesn't pump as well as it should do. Arrhythmias mean you can get funny heartbeats. The sleep apnea I've mentioned, that's where you get problems with breathing, particularly at night when the airway tone goes down. There's a bit of an association with malignancies, particularly colonic, so in the bottom of the bowel, and also thyroid is the two that are described in detail. Arthropathy, early, it's a degenerative arthropathy that people get when they're younger. You can get fractures of those blocks in your back, and obviously just not feeling so well. That impaired well-being is important. The other thing that is important to know is acromegaly is associated with an excess mortality, which we'll go into a bit more detail about now. So the original studies that noted this back in the 1990s were based around people who are untreated. And the SMR gives you a multiple of the background mortality. So an SMR of 3.4, so standardized mortality rate of 3.4, means you are 3.4 times more likely to die if you got acromegaly than if you didn't. So it was quite high in untreated disease. The more recent data, when we're looking at populations in general, have shown that that's down to about 1.7 now, but that's a mixture of untreated and treated disease. And the predominant causes of the excess mortality were heart disease, respiratory disease, and more recently we've noticed an increase in malignancy, but that's probably because people are now starting to live a bit longer with the disease. Now we can manage it better. We also know that if we bring your growth hormone and IGF-1 levels down to normal, then the mortality goes completely back to normal. Our target growth hormone is less than 1, and then we need to normalize your IGF-1 to your age, to what should be for your age. Also very promising is the change over time in mortality. So that mortality rate in a cohort before 2008 was 1.76, and since 2008 it's now 1.35. So it's all going the right way. We really are making big inroads into getting rid of that excess mortality, thank goodness. And the same for the heart disease. It's gone down from about 2.4 to 1.7. So all getting better. And the more we can control these numbers, the better it's going to get. What are we aiming to do with treatment? Well, number one, we want to get rid of the symptoms you've got. So if you feel unwell and have symptoms, we obviously want to resolve those for you. A lot of them, as I said, were big tumours, so they expand and can hit important structures around the pituitary gland, so particularly the nerves to the eyes, and cause problems with visual fields and loss of sight. So really important to get that tumour bulk down. We obviously need to get that mortality down, and all those complications I mentioned, we want to either prevent you getting them or manage them so that they make less problems. We mentioned the IGF-1 is great. Bringing the IGF and growth hormone down to normal helps mortality, but it also can reverse some of that, those complications if they're present. And if the complications don't go away, bringing those numbers down actually make them a lot less troublesome and a lot less prominent. What are our treatment options for acromegaly? Well, it's a mass in our pituitary, so the first line for almost all individuals is surgery. If we undertake surgery and can take out this little nodule in the pituitary gland, then hopefully the IGF-1 and the growth hormone levels will fall to normal with surgery alone. And it will do so rapidly. Within 6 weeks, you'll have a normal growth hormone and hopefully also a normal IGF-1. So that's the best therapy by far. Radiotherapy, we don't use as the first treatment anymore. It tends to be an adjuvant and tends to come after surgery and medical therapy nowadays. So it's become a later treatment. Medical therapy, the one most people would have heard of, were the somatostatin analogues. So these are probably the ones we use a lot more than all the others put together. And they mimic the natural hormone that comes down from your brain to turn off your growth hormone. So somatostatin is the hormone that switches off growth hormone in the normal pituitary gland. And all we've done is make drugs that mimic that and much more potent and last a lot longer. And they're called octreotide and lanreotide. We usually use those about as a once monthly injection, and they work very well. We also use other drug classes called dopaminergic agonists. So they hit the dopamine receptor, which is another one that's involved with controlling growth hormone in the pituitary. Not as effective as the somatostatin analogs, but still very helpful. And then we have a drug that acts in the periphery around the body called pegvisomant, and that blocks the action of growth hormone in the tissue. So that works in the periphery, not on the tumor, but out on the tissues to stop the growth hormone from having any action. However, it's common that we're going to need a combination of 1, 2, or even 3, 4 therapies to get growth hormone and IGF-1 levels controlled. So if we look at this, this is something we worked out for one of our publications. If you have first-line surgery, we only control somewhere between 40 and 65% of people, depending on which series you read. So on average, around 50%, which means about half of the people are over here in the persistent disease despite surgery. We then add in somatostatin analogs, which controls around 30 to 40% of people of this group, which means we end up with another 19% controlled, but we still got 26% of that original 100%. So about 1 in 4 people who, despite surgery plus the somatostatin analogs, need further therapy. So 1 in 4 people with acromegaly are going to need surgery, somatostatin analogs, plus something else. What other advances have we had recently? Well, surgery's got better, certainly visually. Rather than just looking down a metal tube with a microscope, we now use endoscopic surgery. So similar to what we do when looking down your tongue, we can use fibre optics and look around the corner. We can visualize much, much better, see any bits we've missed in the surgery. So that's been fantastic for the surgeons to have. Neuronavigation's also made a major difference. That means when we have a base of skull surgeon that works with us, and he does CTs before the operation and works out using the neuronavigation equipment during the operation exactly where we are when we're going through the nose and through the turbinates and all the bits of bone around the nose to get right next to the pituitary before the neurosurgeons take over. Radiotherapy's moved on. From conventional radiotherapy, we now have stereotactic, which is highly focused, single shot radiotherapy. The old stuff, you used to have to come to hospital every day for about 5 weeks to have a small fraction of the radiotherapy, but now stereotactic, single dose, 1 visit. Proton therapy is something people may have heard of. It's the big rage in radiotherapy at the minute for all conditions. And rather than shooting X-rays, it shoots a solid particle called a proton. A proton is the part of the nucleus of an atom. So these are really, really small but solid particles. And it just means you get less scatter with those, because when you shoot them at something, they stick in it and they don't bounce off and cause damage to structures around it. So proton's quite an exciting development, but we'll see where it goes. There's only 2 machines in the UK, one in Manchester and one in London. And they've only just built the facilities for those to go in. Medical therapy's moved on a bit. We've got a new somatostatin analog. We had, as I mentioned, one called lanreotide and octreotide, but we also now have one called pasireotide, which affects more receptors, somatostatin receptors, than the old one. So in some people who are resistant to the previous drugs, pasireotide will work. We also have in development a tablet version of octreotide. So all octreotides, all the somatostatin analogs to date have been injections, but we've got a tablet formulation in development at the minute, which looks as though it's equivalent to the injections. And we also have a new injection, which will be using a very fine needle to inject, and people will be able to self-inject once a month as another option. So how about all these complications we've mentioned? Well, again, just to re-emphasize the importance, early diagnosis makes a big difference. If we catch you before we've got any complications, easier to prevent them. Getting the IGF-1, the growth hormone, down as quick as possible, again, really important. And that's emphasized by this little bit here. You can see 3 different patients when they're diagnosed at time 0. One, the bottom one down here, this one here, we bring down this patient with little circles very rapidly on the growth hormone. And you can see that person you'd expect to have a lot less complications than this person up here with the triangles, who's taken 10 years to come down to being under control. So that's why the importance of rapid, there's a lot more growth hormone exposure for a lot longer with this patient than there is with this patient. So really important. And again, we mentioned the IGF normalizes mortality. Surveillance, what we do and complications that people will get is very different between individuals, and so it needs to be individualized because obviously some people undergo surgery, some with somatostatin analogs, some have multimodality treatment, and all of those treatments have different implications as to what we might want to look at going forward. There's also those people that aren't controlled and aren't uncontrolled, which have an IGF that's normal, but a growth hormone that's high, or the other way around. We call those dichotomous, and that accounts for up to 25 to 30% of people with acromegaly once they're treated. So what do we see? So diabetes is really common. At presentation, it's somewhere between 12 and 37% of people with acromegaly have diabetes. Diabetes in the UK has a prevalence of around 9 to 10%. So this is significantly above what we've got in the background population. And in addition to diabetes, you've got people who've got glucose levels, sugar levels, which are high just when you check a blood before they eat, and other people after they eat who don't clear the sugar as fast as they should do, which we call impaired glucose tolerance, IGT. So they're all things that are wrong with sugar control that happens in this disease. And the reason for it is growth hormone is one of the hormones that normally keeps your sugar up. So insulin pushes it down, and growth hormone is really important in keeping it up. So if you get too much growth hormone, it pushes the sugar too high. And that induces resistance, therefore, to your insulin and makes your liver make too much sugar. And it stops the B cells, which are the ones in the pancreas making insulin, from working properly or overworking such that they fail. If we're successful in your surgery, though, a good 23 to 58%, so usually about 40% of the people with diabetes, it completely resolves if we can push you into remission with the first surgery that we undertake. But even with that degree of resolution, there's still an increase. We never get down to that 9 to 10% of people that we see in the background population. We've still got somewhere about 15 to 20% of people with diabetes who've got acromegaly. One of the reassuring things, however, is that the prevalence that doesn't tend to go up with time, which is good news. And a lot of the people who get diabetes, it's generally those which we haven't controlled with that surgery. Medications make a difference. Both the pegvisomant, the growth hormone antagonist, and the dopaminergics I mentioned don't make any difference to your sugars. If anything, they make them better by lowering the growth hormone. The somatostatin analogs, lanreotide and octreotide, can make a little bit of difference to diabetes because they also inhibit insulin slightly, but generally they're fairly neutral. Whereas pasireotide, the newest somatostatin analog we've got, actually switches off insulin, so it can give you diabetes even if you don't have it yet. And that's up to 60% of people get hyperglycemia or diabetes with that drug, so I don't tend to use a lot of it. Management is pretty much as we would do for people who've got diabetes in the community. It doesn't differ particularly with acromegaly. We still want the lifestyle measures, losing the weight, avoiding sugars in the diet. We use metformin first line, which we do in type 2 diabetes in the community, but it makes even more sense in people with acromegaly because the way metformin works is exactly the problems that too much growth hormone causes. If you've got diabetes, you still need, if it's due to the acromegaly, you still need all that screening for the blood vessels. Diabetes damages blood vessels, and that's how it causes problems with your eyes and your kidneys and your heart. So you still need all that screening, people looking at your feet, digital photographs of your eyes, etc., if you've got diabetes from acromegaly. So important that that's undertaken. So malignancies. There's been a lot of I suppose, work around this area over the last few years relating to acromegaly. We know that growth hormone and IGF-1, if you have these immortal cell lines that you can grow cells in a petri dish, which are cancerous type cells, if you treat them with growth hormone or IGF-1, they grow faster. You can also put cancerous cells into mice or rats and give them small cancers, and if you then give them injections of growth hormone and IGF-1, their cancers grow faster. So there's certainly some preclinical data that would suggest that growth hormone and IGF-1 are bad for cancers. There's also epidemiological, so that's population data that we have from the healthy population over thousands of people. And if you've got a high IGF-1, you're more likely to get cancer than a person who's got a low IGF-1, even if you're normal. So a normal high is associated with more cancer, and a normal low, less cancer. Even that's so in the population, you may get less cancer by having a low IGF-1, but you get more heart disease. So there's no winning in the normal population. You get one or the other if your IGF's set. So some of the data around cancer still remains very controversial, and particularly relating to individual cancers, because we don't often have enough of them, especially in rare cancers. So if you've only got a infrequent cancer, we don't actually get enough numbers to really be sure if that cancer's increased. Also, a lot of the data in the acromegalics, the people we're looking at with acromegaly and cancer diagnosis, it's often people that were treated 30, 40 years ago. And so they've not been treated how we would treat people now. So the data may not be relevant to what we're doing now. The two cancers I mentioned were thyroid and colon. So thyroid cancer is the well-differentiated thyroid cancers that we see an increase of. So these are fairly low, very slow-growing, indolent kind of cancers. And we know that because if you find them earlier in the normal population, it makes no difference to outcome, whether you find them earlier or you find them later once they've grown a bit. Also, if we look for these in post-mortem specimens, about 1 in 4 normal individuals has a well-differentiated thyroid cancer. So they're really, really common. So in the acromegalic population, the growth hormone, the excess growth hormone and IGF-1 means the thyroid is larger, it has more lumps and bumps in it. And if you go looking, you can find these small little cancers that don't really matter. And that's probably why the incidence of thyroid cancer is increased in the acromegalic population. I suspect, however, we shouldn't be looking for these, and I certainly don't do ultrasounds to look for them. I also run the thyroid cancer clinic here in Leeds. I have over 800 people with well-differentiated thyroid cancer, and I have nobody who is in both of my thyroid cancer clinic and my pituitary clinic for acromegaly. So I don't think this is the issue it's made out to be. Colon carcinoma probably is a bit more real. The meta-analysis, which is putting all the studies together, would show that there's an increased risk of 3- to 4-fold for polyps or cancers. So I think this is a true finding. So I think we need, in people who've got acromegaly, we need a screening colonoscopy at the beginning when they're first diagnosed. And that can be after we've initially sorted out the first surgery and got things sorted. It doesn't have to be before you have all the surgery and get the growth hormone down. We can do it a month or 2 later, but somewhere around diagnosis, we need to check and make sure there aren't any polyps or anything going on with the bowel. It's associated with active disease. And if you have polyps on a colonoscopy, you need another one. If you have a clear colonoscopy and you've got controlled disease, you probably don't have any risk of going forward. So hopefully if we can control disease and the first colonoscopy is clear, no more of those. But I think they are important. Sleep apnea. So this is a really high prevalence in patients who get acromegaly. It's due to the increase in the size of the tongue and the increase in the soft tissues in the pharynx and larynx. When we fall asleep, the tone in those muscles goes down. And so the tissues become a little bit more floppy, and they can then block the airway a bit. It means people then get blocking of their airway when they go to sleep at night. They often snore a lot, and they wake up because their airways have become blocked by the soft tissues. It's associated with an increase in cardiovascular disease if we don't treat it and leave it long term. But more importantly, people who've got sleep apnea really do feel a lot more lethargic in the daytime. And that's the same if you've got sleep apnea outside of acromegaly as well. So common cause. Once we've controlled disease and got the IGF and growth hormone levels back to normal, there's still around 40% of people who will have sleep apnea. So it's an important thing for us to look for and try and manage. One of the biggest factors towards getting sleep apnea is weight, certainly in a normal population, but that's also true within people who have got acromegaly. How do we screen for it? We do a Epworth sleep scale. So this is a questionnaire, which is really a questionnaire about being tired. And if you score over 10, then we probably should be doing a screening test. The screening test is just like wearing one of these little sleep monitors that tell you your oxygen saturations, and you wear that overnight and see how many dips you get. So these are the ODIs, these are oxygen desaturation index. So that's how many little dips you get of more than 4% in your oxygen levels. And if that's positive, then formal sleep studies to see if you have got sleep apnea and what type of sleep apnea you've got. And then we can manage that by providing CPAP. So continuous positive airway pressure is really what it says. So this is like a ventilator that just blows softly. You wear a mask when you go to sleep, and it blows a small amount of air into the airway to keep it open and stop those tissues from collapsing. It makes a big difference though to lethargy and tiredness the next day. So really important we know about. Arthropathy. This is one of the biggest problems in the long term for people who get acromegaly. At the end of the arthropathy, you end up with symptoms very much similar to that of osteoarthritis, with joints which are irreversibly damaged. It's a non-inflammatory arthritis, so similar to our osteoarthritis, so similar to wear and tear arthritis that we get. And it can affect the big joints like the knees and the hips. It can affect the small joints in the hands, and it can affect the spine. When it first occurs, you get expansion of the cartilage, and on the, if you can see this X-ray on the right-hand side, there's an increase in the cartilage thickness there. So the bones look a long way apart, but because that cartilage is expanded, it's actually a lot softer. So once you start using it, once it's expanded, it wears away rapidly, and you end up with a degenerative joint and the two bones pressing on each other. It may, if we catch it in this early stage, when it is expanded though, it might be reversible. If we can get your growth hormone levels down at that time, it may be that we can prevent the arthropathy progressing. It's likely, however, because the best predictor we can find of who gets arthropathy is actually their growth hormone and IGF-1 levels when they're first diagnosed, which would suggest that some of this damage is actually done before we even pick up people with acromegaly, and therefore, again, importance of trying to find people early. Management, pretty much like osteoarthritis, there's nothing specific as yet to try and deal with this, other than obviously diagnosing earlier, getting the growth hormone and IGF-1 levels down rapidly. It comes down to physiotherapy, analgesics, and joint injections and joint replacements, which is same as wear and tear arthritis, really. Vertebral fractures is another one we see. So these are little blocks in our back which can be broken. They're usually fairly minor breaks when you find these. So they're not true osteoporotic crush fractures that we see in older postmenopausal women. These are different. They're very minor. Growth hormone itself makes your bone turnover much quicker. So it makes you make more bone. It makes you break down bone. It does all of that a lot faster. But it tends to do more of the resorption than the making bone. So more bone is lost than formed. So again, they're people with greatest risk, those who've got most active disease as the high IGF-1, those who have disease for longer, and people who've got previous vertebral fractures. If you fracture one vertebral body, you're much more likely to fracture another one. And particularly men who have lost their testosterone levels because of the size of the tumour with acromegaly are more likely to get vertebral fractures. Less obvious in women who have lost estrogen. Bone density is something we use usually to get an idea of bone strength, and it's good in a normal population. We can sort of predict who might be at risk of getting fractures, but it's not as useful in acromegaly, and that's for a number of reasons. In the series of acromegalics, we see some have increased bone mass, some normal and some reduced. So the series hasn't helped us to delineate whether there is a real change in people who've got acromegaly. If it's low, it's often because the low testosterone or low estrogen hasn't been treated properly. And then we get abnormal results from DEXA because bone densitometry is basically x-rays. And depending on how many x-rays go through the bone, it will tell us how thick your bones are. But because you get the osteophytes, these are extra bone growth around the joints, and you get an increase in the outer shell of the bone, not the inside of the bone. The inside gets thinner, but the outer shell gets thicker, and the vertebral bodies look as though they get slightly bigger. Then you get calcium in the ligaments, all of which stop the x-rays getting through. You can get high DEXA scores, even if your bones are quite thin in the middle of those blocks. So DEXA is not the best measurement. We also use something called FRAX to work out people's risk of fractures in the future. But again, doesn't work very well in people who've got acromegaly because it relies heavily on the DEXA scores as well. How do we prevent them? Again, it's controlling the IGF-1 and growth hormone levels. And again, it just shows how important this is to all the complications that we see. We need to make sure vitamin D levels are okay because that's what helps calcify your bones. Make sure we don't overtreat your with hydrocortisone for steroid replacement because they weaken your bones. And obviously making sure there's adequate testosterone or estrogen replacement, which are anabolic and build up your bones, so really important. We do obviously have drugs out there we use for osteoporosis, so as long as we're picking this up and know who's at risk, then obviously we can treat this. Quality of life is the last thing we'll mention, and that I suppose is one of the big things for people who've had acromegaly for a long time and still have quite a few symptoms from it. And we see it controlled in impaired quality of life, both in people who've got uncontrolled disease and people who are controlled. We also had a 5-year study where we looked at quality of life in patients with acromegaly when they were uncontrolled at the beginning, and then we tightened up their control. And 5 years later, despite that, quality of life didn't improve. So there is something to this disease that makes people feel tired and unwell. And it's not yet clear to me how we make this better. There are a number of factors which probably contribute, though. The fatigue side of things, the headaches, the joint pains, appearance came out in studies where they questioned what people impacts on their well-being. And I think medicalisation and the fact that we keep doing all these tests on people and bringing them to hospital doesn't help either. So fatigue, what's causing that? Well, the sleep apnea we've mentioned is probably part of it. And not being as good as your body at giving back the other hormones you're missing, like steroids and sex steroids, etc. We can overtreat people with acromegaly, particularly after radiation, and that can make them growth hormone deficient. You start off with far too much, and we overtreat you, you can end up with too little, which can make you more tired. Diabetes needs to be controlled. Anyone who's got uncontrolled diabetes feels more tired. And then obviously it may be that it's contributed to by other factors which really aren't linked to the endocrinology that's going on. That's an idea of what happens with your steroids, just to emphasize how bad we are at replacing hormones. This is normal. Your steroid levels climb up in the morning. They peak just before you wake up in the morning, and then they go down through the day. This is what happens with steroid tablets. We can't do anything overnight because you're not swallowing tablets. And then we give you a tablet in the morning, your steroid levels go up and they go too high, and then they come down, they go up and down through the day whenever we give you a little bit of tablet. But we're missing all this bit here, which is all this. So how important is that? And how important is it to wake with steroids in the morning? Will that make a difference to us? We don't know yet, but there's a new steroid preparation on the market called Acromegaly, which you'll take at night time. It will do nothing for 4 hours, and then it will start releasing about 2 o'clock in the morning. So we will be able to mimic this in the future. It'll come down to cost and whether we're allowed to use it, but it's looking good on paper. And it'll be nice to see if it makes a difference and people wake up with tons of energy once we start using it. Testosterones. This is what's happened over the years. We started off with these implants, which we used to do a little surgical cut in your abdomen and put a pellet under the skin. And then we got short-acting injections you'd have between a week to 2 weeks. And then we had a oral testosterone as a tablet form. You have to take it 3 times a day. You have to eat it with fatty foods to help it be absorbed. So you put your cholesterol up. And then we developed this testosterone patch here, this big one. And they decided when they first had it that they'd put it back physiologically. So you had to shave your scrotum and stick your patch to your scrotum. So that wasn't a good idea. And then they decided actually you didn't need to do that. And so we could have patches you could stick on your arms, which is what happened here. And then we had the testosterone-based gels, which is one of the ones we use as a mainstay of therapy now. The gel is alcohol-based. You rub it on your skin, absorbs through your skin over about 2 hours, and then lasts all day long. So that's good. There was a buccal testosterone. Buccal means lip, and you used to put it under the little gap under your lip, and it would sit there, and you put it on morning and night. Dreadful preparation. I went for a whole pack of placebos trying to get the things to stick, so that's no good either. And then there's the long-acting injection, which is Nebido, which is an injection which lasts about 12 weeks on average into the gluteal muscles of your bottom. So you end up with 4 injections a year. So that's the other one. So we use the gels and the long-acting testosterone injections now. But how physiological are that lot? And there are all the different preparations, none of them looking particularly normal for testosterone, except for this 50 microgram gel. 50 milligram gel. The testosterone level goes up in the morning when you apply the gel, down through the day. And that's what normally should happen. That's about a normal level. That is the only one of all those therapies on there that's anywhere close to what we naturally would see with testosterone in your body. All the others are a long way off. So again, they may all be things that are contributing because we're not doing it right to making us more tired. Growth hormone deficiency. So we recognized in hypopituitary patients, so people who've got pituitary problems and from whatever cause really, except for acromegaly, that if we damage the pituitary gland, you don't make growth hormone, and adults who have no growth hormone feel more tired, they have less muscle mass, they have more fat mass, they have a higher cholesterol. So we started in 1989 when they started being able to make growth hormone in the lab. We started giving it back to adults to see what it did, and it showed a benefit. And then we used growth hormone. It got licensed after all these studies in '96 in the UK. The National Institute for Clinical Excellence said we can use it in adults in 2004, and we have been doing so since. In hypopituitary patients, it improves their quality of life, particularly the fatigue, and that's the only thing we're allowed to use it for in the UK for adults. So growth hormone replacement in adults is for people who feel fatigued, have poor quality of life. It does a few other things you like, but we can't give it for those. So it increases muscle mass by about 1 kilo, it reduces fat by about 1 kilo, it reduces cholesterol a bit, reduces clotting factors a bit, so that lowers your risk of heart disease. And in young people, it increases bone mass and helps you acquire bone mass. So everything about it sounds good, which is why some people take it off the shelf or out the back of a lorry. So in acromegaly, really growth hormone deficiency sort of means we've effectively treated your acromegaly, and probably a little bit too effectively. We've pushed you down from being too high through normal and out the other side into deficiency. And it happens. It's usually associated either with radiotherapy quite a long time ago, or a surgical hypophysectomy, which means they've taken out all of your adenoma for the growth hormone, and your pituitary gland's gone with it as well, and you've got no hormones left. To know if people with acromegaly have got it, they usually have an IGF-1 level, which is in the lower tertile, the lower third of normal or just below. Growth hormone levels themselves will also be very low, so probably less than 0.3-ish on a random growth hormone. If we give it back, it's in these automated pen devices similar to what diabetics use. Once daily injection, because it's a peptide, you can't have it as a tablet or just get metabolized just like meat does, like protein. So it needs to be injected. There are a few studies out there of using growth hormone in patients who have had previous acromegaly who are now growth hormone deficient, and the benefits are just as good as in other patients who've got hypopituitarism. So it is there, and I think it gets forgotten about a lot in people because we assume we used to have too much growth hormone. It sounds counterintuitive, really, doesn't it, to give you back some growth hormone after you've had far too much in the past. One of the other things I think that affects quality of life is headaches. We know on presentation, the growth hormone secreting tumours and the prolactin secreting tumours are much more likely to give people headaches than the non-functioning tumours or the TSH secreting tumours. So these two tumours, which are actually quite similar in their characteristics, cause more headaches, up to 70% when you're diagnosed. And we're not really sure why they cause more headache. We don't know if it's an increase in pressure, but if it was just that, why would it be different to other tumours? We wonder if it's releasing a pain-inducing peptide. That's what a nociceptive peptide is, one that causes pain, or whether it's a direct action of growth hormone, but we're not sure. But again, helped by tumour control and lowering the GH and IGF-1. But despite that, even if we do control people, there's a small proportion of people who have really severe headaches despite completely normal growth hormone and IGF-1. And we're not sure why they get it. It tends to be more so in people who have big tumours and that have gone to the side a little bit, that have grown into the edges of where the big vessels are that drain the blood in and out of the brain. Headaches are usually on the side where there's that little bit of tumour left as well. And they usually don't respond to tablets and painkillers at all. So not helpful. But what we can use is that octreotide that I say we usually use as a monthly injection. There's a short-acting one that you can inject yourself with. And that is highly effective in a small dose of 50 to 200 mics. And it works on these specific headaches rapidly and resolves them completely. And again, I think this is something we do too little of. The background somatostatin analog seems also to reduce the need and how often you need this. But on the study we've been involved with, it's somewhere between we've got 18 patients that are having these really bad headaches, and they're injecting between 4 and 12 times a day to help their headaches with this short-acting stuff. So long-term surveillance, that's all the millions of tests that we end up doing on you, but it all needs to be individualized. So once people are controlled with their growth hormone and IGF-1, a lot less surveillance is needed, and we can cut out most of all that lot over there on the left-hand side. But really important that we do undertake all these tests, and they're particularly important right at the beginning when you've got new disease and the effects of that, which we haven't yet characterized. So I think we're there now, and we'll hand back to Dan to take us forward, and then we can answer any questions people have.
Rob, thank you so much for that. You can tell you work for a teaching college, because I've listened to quite a few talks in my time, and I think you've explained some of the more scientific and technical aspects of that so precisely and, you know, brilliantly well done. So thank you. Clear, concise, not too over the top, especially at 7:30 on a Tuesday, Wednesday night? Wednesday night. So really, really well done. And I'm sure people will send their appreciation in the chat panel, maybe. I guess just I'll give you a little bit of background about my story, and a few people may know this already, so I won't take too long talking over it. Before I had acromegaly, I was diagnosed with a very rare condition at 4 years old called Wyburn-Mason syndrome, which is a vascular abnormality, and it's in my retina. No, it's not. It's in my optic nerve and my midbrain. And it only affects about 1 in 60 million people. So when you think acromegaly is rare, this one is like hyper rare. And by the age of sort of 10 years old, I was left blind in my left eye and short-sighted in my right eye. But life was normal and I got on with it. But in my mid-20s, I did start to notice that things were odd. I had no love life, or I had a partner, but I had no desire to do anything. My hands did grow, and I did get a ring cut off my finger. My feet did go up 2 or 3 shoe sizes. I had no energy to do anything really. And I just thought, I'm 28, 29, I'm getting old, which is a terrible thing to think at that age. And really, it was by complete chance when I went Bristol Eye Hospital contacted me and asked me to go in for an OSCE, which I'm sure you know what an OSCE is. For those that don't know, that's a final year exam for for medical students. And I was sat in the chair and the medical students are wheeled in one at a time, and the examiner would say, okay, here's the patient, what are your observations? Before they even looked in my eye, they took a step back and they're going, well, he's got very large hands and a protruding jaw, big furrowed brow, exposed gaps in the teeth. And I'm sat there thinking, no, it's white blood Mason syndrome, you've got it completely wrong. And then the examiner goes, so what do you think that might be the cause of? And they were all going, could be due to excessive release of hormones due to pituitary adenoma. And I'm sat there, I'm 30 years old, I have no idea what this means. And once 4 or 5 had said it, I was starting to get slightly concerned. And I said to the examiner, they're saying all these things, what do you think it might be? And he said, you should go and see your doctor, you might have something called acromegaly. Thanks very much. And then waved me out of the door. And sort of just left me to it, really. And then I literally left the hospital, typed acromegaly into Google, and which is not the same as typing symptoms into Google, I will hasten to add. And that was it. And I knew that was what I had, and it all completely made sense. And for me, it was like a complete hallelujah moment, because for 5 or 6 years, I had felt like crap and I didn't know why. And the fact that I knew that there was this little thing growing in my brain, and when I had the blood test done the next day and they came back a few days later, it was like, yeah, your growth hormone levels are off the scale, then things could proceed. So I know everyone has obviously got their own stories, and I was very lucky that mine was about 7 millimeters, so it really wasn't very big at all. It was caught early, and literally within weeks of the surgery, my facial features returning back to some sort of sense of normality, hands and feet going back to some sense of normality, and life going back to some sense of normality, and especially a sort of sense of energy. And I needed no medication. I needed no additional treatments. The only thing I was put on a few years later was testosterone injections, which I am still on now. And that graph that you showed was very interesting, because I initially started on gels, and I didn't really think they did anything. And then I got put on the injection. It's like, whoa, here we go. It's like the biggest boost of testosterone ever. You feel like, King Kong. But then it kind of, and then it really does sort of slip away quite quickly. And I've noticed as well that I get massive spikes in hunger about a week after my injection. I could eat for England, and I want to manage that, because I'm on a diet and I am doing really well, but then I'll have major sugar cravings, or it will really bounce up and down. So I'm actually spoken to my endocrinologist, and I'm going to move to the gel and try it out again, because I'm in remission now, and I don't know if I need the injection as much. So I want to try it for 6 months and see what happens. And that leads me on to the question that Mike asked, which is, how would you define remission? Could you clarify that for us?
Yeah, I suppose what we want are multiple things, really. So the important thing, biochemical remission will be a growth hormone less than 1. And for that, we'd usually do a day curve. So here we bring people in for 3 hours and do bloods every 30 minutes. And then look at the average. If it's below 1, we're very happy. And so that's that. And then IGF-1, we would want normal for age. The range for IGF-1 goes down the older we get, because we naturally make less growth hormone. So we need a normal age-matched IGF-1. A growth hormone less than 1 on a day curve is ideal. So that's biochemical control. And then you're going to have control of the tumor itself, which is different to having biochemical control. So then we have to think about if you've got a tumor remnant and if that's controlled. In the vast majority of people who are on somatostatin analogs, that controls tumor growth. So usually they're in remission from the tumor side. A lot of the other aspects and problems are sequelae from the previously elevated growth hormone IGF-1 rather than being a consequence of active disease. So the remission is going to be defined by that biochemistry and by the imaging. Growth hormone acts as a great tumour marker, so you can't get an enlargement of your tumour unless your growth hormone goes up. You know, if you're making more tumour cells, your growth hormone's got to go up with it because they're growth hormone secreting cells. So you've got a tumour marker as well. So you don't need to keep them scanned when you've got acromegaly because you're telling us with your numbers.
Yeah.
Thank you.
Okay.
Thank you.
Does that help, Mike?
Yes, thank you. That's great.
Okay. We'll just come on to, there was another question just coming in a second. We did prepare a quick poll. Could we launch the poll? Because we were interested to see in this chat where you're at in your journey. So can you select whether you're recently diagnosed, diagnosed 1 to 3 years ago, 3 to 5 years ago, 5 years plus, or whether you would consider yourself in remission? And we'll see what the poll suggests. So we'll give that 20, 30 seconds or so. While you're doing that, I did sort of inadvertently manage to leave my book lying around. So if anyone wants to hear the rest of my story, I don't know how it got there. It just happened to be lying here. If you want to sort of know more about the whole journey, get in touch with me and I'll get you a copy. Don't buy off Amazon. They haven't got any left actually, which is very reassuring. But yeah. Anyway, pitch over. Do we have any results? Here we go. So in the room, we have recently diagnosed. We have 21%. Welcome to the club. Diagnosed 1 to 3 years ago, 7%. 3 to 5 years ago, 14%. 5+ years ago, 36%. And would consider themselves in remission, 14%. One person's put other, and I'm not quite sure what that relates to. That maybe they don't have it at all and they're here as as in support or in a caring facility or something like that. So I think if we can keep that open for the moment, that will be really useful because again, we know who to sort of aim the conversation at to some extent. We had another question come in from Helen. I know the oral sandostatin is prescribed in the US and trials here have ended. Any idea when it will be on available prescription? I want to go traveling, but have my injections every 3 weeks to keep everything under control.
No, I'm not sure if the company it's Chiasma, I think, who make the one that's available in the US. And I'm not sure they've been going for European or UK licensing. The newer version, which is coming out, so the one that's taken at the minute in the States is twice a day. You have to have it fasted. You're not allowed to eat anything for 2 hours afterwards. It only controlled, I think, somewhere about 57%, from what I remember from the paper, of people who were already controlled on injections. The newer one that's coming out from that we're working on, which is in its phase 3 study at the minute, is the better preparation. It will only need to be taken once a day. It has, at the 40 milligram dose, it's equivalent to somatostatin injections. They've just released a 60 milligram dosage that we're going to up a couple of patients to, that we're studying here. You can't eat anything after it for about an hour to help it get absorbed. You can't be on protein pump inhibitors so they're the drugs like omeprazole, lansoprazole that people use for stomachs, with either of the oral preparations. And a lot of people are on those kind of drugs. The other one that might be helpful is the Crinetics drug, which is the one you inject yourself. It's a much, much smaller needle than you're used to with the current somatostatin analogues. And you can inject yourself, or your partner can inject at home, rather than coming to healthcare professionals to do it. So that'll be another option. So both of those. But in reality, if we're doing phase 3 studies now, it's probably 3 to 4 years off on the products we're looking at now. But I don't think Chiasma are going to bring theirs over to the UK.
Takes an eternity, doesn't it? to get these things approved. It is not an easy process. Thank you for that. Thanks for the question, Helen. We got a question from Trish. Thank you, Rob, Dan, and the admin for this. Very informative. I am 4 months post-surgery. I was diagnosed with acromegaly via a Rankthe's cleft cyst and an adenoma too. I also have Sooner syndrome, apparently. Should the Sooner still be a thing at this age? I don't know what Sooner is. Do you know what Sooner is? No. Could Trish maybe expand on what Sooner is? Feel free to turn your microphone on.
I will now. It's apparently via the neurosurgeon that took away the RCC and the adenoma. It's a headache syndrome, but it causes your eyes, because I originally thought that, you know, my vision was bad, so I thought, oh, it was something to do with, it was touching the optic nerve or something. But apparently it's a syndrome that with any kind of pituitary cyst, so whatever, adenoma, causes your eyelids to droop, which is, it's quite frightening actually, because in the first place I just thought it was that I was tired, but apparently it's you know, quite a rare thing. So obviously if it's that rare and nobody really knows about it, it's similar to SUNCT, if you know what SUNCT is, which are, you know, it's sort of like short-term headaches, which I'm still getting actually, which is, you know, an issue for me because you know, the adenoma has been taken away, but I'm still feeling quite rubbish, and that's with all the levels being at the moment all right.
Can I just answer that from a patient's perspective? Expect to feel rubbish probably for about a year. I really mean this. Even if your levels are fine, I think your body's taken a battering. And everything is taking time to settle down, realign. I was in pain for months. My lower back was killing me. I felt crap, all of these things. But honestly, 6, 8, 10, 12 months. And every month you start to feel a bit better and a bit better. But, you know, it was, for most people, I think it's really 3, 4, 5 years until you start to feel back to where you were. And then, but you've got to compare that to where you were pre-surgery. And normally there's quite a big difference between that stage and where you are post-surgery.
Thank you. Thank you.
I don't think we can help you on the Sooner side.
Okay, all right. I'll go back to
we need to go. Yeah, we need to refer that to the rare disease department.
Okay, thank you very much. Okay.
The Rankthe's cleft cyst is just a developmental thing where the front bit of the pituitary joins the back bit in development, and you get a little bit of fluid in between. So really common.
Okay.
And they don't matter. We see loads and we just discharge them when we find them on the scans.
Thank you for that. We have a question from Sonia. Thanks for the interesting presentation. What information is there from research on impact of long-term use of medication, e.g. lanreotide? Does it increase our risk of problems with our pancreas later on?
No, it doesn't seem to. 15 to 20% risk of getting gallstones because it inhibits gut hormones as well. So 1 in 5 chances you're getting gallstones in the long term. But otherwise, no, when you come off of it, then things go back to normal in regard to insulin secretion from the pancreas and stuff. So there's no other long-term sequelae for being on them that we're aware of.
Okay, thank you for that. I'm just going to jump ahead because somebody, H. Wad, has said, I have Sooner too. It's amazing that 2 people in a room of 17 have both got this very rare symptom. It's very rare in acromegaly, only 1% get it, doesn't respond to anything. So I think, Rob, that's something for you to...
Yes, to me, so
find out about. And I think this goes to show the level of questions and understanding of the condition. We have to become experts. We never had an interest in this before we were diagnosed, and then suddenly we're thrust into this world where we have to really understand some very, very complicated stuff. And it's amazing how sometimes those living with this I'm not saying they're more knowledgeable than the experts, but they can come up with a different angle that maybe the experts don't always see. And I think this is, you know, where things like this are really, really vital. Is there a difference between an adenoma and a growth hormone secreting cell hypertrophy?
Yes. An adenoma is a benign tumor of a gland, whereas a hypertrophy just means the normal tissue is overgrown. Usually if people have got hypertrophy or growth hormone hypertrophy, it means your normal pituitary is being driven to make more growth hormone. So that's what we see in that 1% that I mentioned who don't have an adenoma and that have such as a carcinoid tumor of the lung that makes GHRH, the growth hormones releasing hormone, which is the hormone that usually would come from the hypothalamus to tell the pituitary how to work. But you can get tumors that make that. And if they make that, you get growth hormone hyperplasia. And you can see that on the histology, the difference between an adenoma and hyperplasia. When you look at it under the microscope by the structure of it, there's a little protein that runs through the gland called reticulin that holds it all together and in shape. And that's disturbed in an adenoma, but completely normal in hyperplasia. If you've got hyperplasia, and it truly is hyperplasia based on the reticulin, then they should be looking for a GHRH secreting tumor or something different that's stimulating the pituitary to make growth hormone.
I think I understood that. We're getting very high level now. On a totally different subject, is depression and anxiety a symptom of acromegaly?
I suspect it's not a direct symptom, but I think because of all the things that go with it, the medicalization, I'd be surprised if a lot of people with conditions like this don't have anxiety and depression from it all. I think the amount of tests and bits we make people go through, all the concerns over these kind of diseases. So I don't think it's direct, but yeah, I think it's all part of the collective, isn't it?
Yes, and I think this is sometimes where the rise in social media plays a bit of a role in this as well. You know, social media can be hugely useful tool to find out information, but it can also offer scaremongering and misinformation. And I'm not saying acromegaly sort of preys on that, but I think when we're searching for information or when we're on forums or Facebook or whatever, sometimes some people can get very overwhelmed by it, and that can then feed into others as well. And when we're dealing with lots of things, we're dealing with a change in our appearance, we're dealing with changes in hormones. It's a lot to take on board, and I'm not always sure engaging with social media at that time is the best idea either. Although at the same time, it can give you tons of information, reassurance, and things like that. So it's just can be a bit of a minefield, I think. And for some people, it's sometimes better to step away for a period of time.
Yeah, one of the things that contributes to anxiety is often doctors, when they find your scan, just tell you you've got a brain tumour. And I'm not sure that's a good way to describe this.
No, so there's a big discussion about this. I mean, do you refer to them as tumours or brain tumours, or are they pituitary tumours?
No, adenoma or benign lesion within the pituitary gland. It's outside the brain as well, so it's outside. It's below the meninges, so it's actually not in the brain.
I think this is a really, it's almost like a campaign that we need to do about this, because I agree with you. It is. I know, you know, brain tumor. How do I word this? It has more impact, you know, as a phrase, I suppose, and more people can grip onto what that means. But then you go, well, it's in the pituitary gland, and people go, oh right, and then you go, do you actually know where the pituitary gland is? And almost 9 out of 10 people I ask go, no, where's that? And you go, well, it's at the back, you know, at the back of the nose and sort of at the bottom of the brain. And they're like, oh right. And you go, and do you know what it does? And they go, no. And they go, well, it's only probably one of the most important parts of our body to control all of our hormones and all of that. So I think I was guilty sort of in the early days of calling it a brain tumor. and then I think I started calling it more pituitary adenoma. But yes, I think there is a sort of there could be an awareness campaign around this, because I think that alleviates the fear of what this actually is. And when you I guess when you look at the success rates of this treatment compared to maybe brain tumors, I mean, this must be a much higher success rate, I would think.
Of course, yeah.
Okay. We have a question, and maybe the Pituitary Foundation can answer this. Will Rob's PowerPoint be sent out or available for us to share? I don't think the PowerPoint will be, but I imagine that the video will be made available at some stage. Is that right?
Yeah, so we're recording this session and we're going to put it up on our website as a permanent resource, probably later next month, at the end of the month, November. So do keep an eye out for it, because it will pop up for anyone that couldn't make it.
Okay, thank you very much. I have a couple more questions. I've started showing symptoms of sleep apnea, especially in the past year. I went to a sleep clinic and wore a device for one night, but it didn't show much. But I keep waking myself up with snorting at night, and I snore a lot, and I am increasingly lethargic. Is it worth asking for another night of study?
Yes, yeah, it can vary day to day. So I've seen people who have a normal response and then they have one done a week later and they've got AHIs of 15. So normal's below 5. So definitely it can vary. So worth repeating. And oximetry is easy to do too. I mean, it's just wearing a probe, isn't it, that tells you what your oxygen levels are. So definitely worth checking again.
Okay. 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 Right. So that was a private message. Okay. Oh, well, thank you for posting up links to the book, and people going, Dan's book sounds amazing. I need 10 copies. What do I need to do? Thanks for sharing the website. That's very kind of you. Or just come and find me on Facebook if you are using social media. I'm trying to think if there's anything else specifically that I want to. I guess one question I would be interested in: what is the potential for those in remission for tumor? Let's not call it tumor. For growth to happen again. Is there always that potential, or is it once you're in remission, you're through the through the tunnel?
Yeah, I suppose there's a lot of factors involved with that. So if you're controlled and in remission because you're on somatostatin analogues, the chances it's going to grow are pretty close to 0.
Right.
All pituitary tumours, the likelihood of regrowth is proportional to how much the surgeons have left. So if you've got nothing in there, then the chances of regrowth are really small. And if you've got a significant bit in there, chances of regrowth are probably about 40%. Okay. So amount in there makes a big difference. Relapse rate or relapses also, like any growths, are much higher at the beginning than later. So the longer you're away from treatment and control, the less likely it is to come back. So most people who relapse and have regrowth will happen in the first few years. If you're 7 years down the line, it hasn't regrown, the likelihood it's going to now is pretty close to 0.
That's reassuring. So yeah, mine was out in 2007.
So ages away. So
yeah. Happy days. I think another area for me is we all know how to live well, but sometimes it's easier said than done. And I think when our hormones are messing around with us, and I've mentioned hunger and tiredness, and I'll open this up to the group, and please put your suggestions in the chat. What suggestions do you have to try and live as good a quality of life as you can? What are the things that we can do, as our own best guides to try and get through this as well as possible? Is that a difficult? And I'm opening that to you as well, Rob. Do you have any thoughts or advice on that, or is that a difficult one to answer?
No, it is a difficult one. I mean, all those kind of lifestyle things, whatever you've got wrong with you, eating well and exercising all make a big difference and make us all feel better. Whatever, whether you're not got a condition, or even if you've got a condition. So they all do help. But how to keep those up is difficult to know, because I haven't touched my gym equipment for at least 6 months. So, and I don't have any diseases I know of that's stopping me from doing that. So it is.
It is difficult, isn't it? It is that sort of, that self-motivation. I really believe this as well, and I do this. If you have the means and the capacity, and you really want to maybe lose weight, or if you want to get fit, sometimes the best money that you can spend is to work with a personal trainer or work with a nutritionist, someone that can give you advice on meals, do your meal preps for you, because those are the things that will A, help you sleep better, B, give you more energy, C, stop you feeling hungry, and therefore you start eating crap because it's the quickest thing to reach for. It's really difficult, but I think there is some great advice out there. But actually working one-to-one with somebody, I think, can be really useful. I think podcasts and YouTube and all of those things can be very motivating as well. And somebody very kindly, and somebody's put meditation, good nutrition, exercise, and acceptance. Yeah, I think that's a very good point. Somebody, thank you, Mike, because I haven't done it this year, actually. I've been a bit lazy on it, but I do a podcast series called Acro Tales, where I interview people about their acromegaly journey. Mike was episode 7, and Trish is actually lined up to be the next episode, which we haven't got round to recording yet. But I think there's over 25 episodes in there, and every story is completely unique. And I think for those particularly that have been recently diagnosed, hearing other patients' stories in whatever capacity it is incredibly valuable. And when you're through the worst and you're feeling better, tell your story and then be a part of that community to help the next group of people that have been diagnosed, because that is sometimes the best way to take this weight and this, this blow that you've had to your psychology and your body off your shoulders a bit, and that's where the acceptance comes in, I think, as well. So I think that's really, really valuable. I think we've got a couple more comments that are really coming in now. This is great. Winifred, hi Winifred. I had surgery in 2000 and since have been on hydrocortisone. First 2 years was hard for me, but then things settled. For the past few years, I've not been very good with back and joint pain and respiratory infections that are very frightening. I'm 64. Do you think I need a change from hydrocortisone tablets?
There's not much that's better than hydrocortisone. If you're adrenaline, you've got ACTH insufficiency, so pituitary is not driving your adrenals, you need a steroid. There's not anything we know that's better than hydrocortisone, I suppose, is our problem, really. There's a couple of slow release ones out there. As I say, F-mode is going to come onto the market. That's probably going to be the best one. Getting hold of it, I think, is going to be tough. Its license is not going to be for adrenal insufficiency. That's why it's going to be tough for us to get hold of it to start with. But I think that will be better. There's a little bit of a move to going over to prednisolone as a steroid replacement. They're pretty much identical molecularly to hydrocortisone, but you only take it once a day. I think in the past we've been using far too higher doses. We've used 5 to 7.5 milligrams, and in reality it's probably nearer 3 to 4 milligrams as a replacement dose. So I think in the past we've got it wrong with prednisolone, and that's why there's some adverse data about it. But one of the studies we're doing in adrenal insufficiency is switching people from hydrocortisone over to prednisolone on once a day on low dose at the minute to see if there's a benefit, or it'll just make it easier for people because it's a once a day, but using lower doses than traditionally has been done. But there's not anything yet that's proven that's better. But slow release and prednisolone are options that you could try.
Okay, thank you for that. Emily says, I was recently diagnosed and had emergency surgery to remove the growth in the summer. For me, the main thing was to believe I am still capable. Traveling, new experiences, concerts, and just believing that life isn't over. Good. And Emily, I don't know if you want to join the call, or maybe you're free to speak if you want to, or type a comment. Did the removal of the tumor open those opportunities for you? Oh, she might be typing. Okay, because that's what I found. Didn't want to do anything pre-surgery. Post-surgery, it's like, wow, life is back. And I know that's not the same for everybody. Oh, hi, Emily, you're there.
Hi.
Hi.
How are you?
Did you? Yes. Did you? I don't know if you heard what I said, but obviously,
no,
for an emergency, did you feel that life, there was a distinct before and after the tumor removal?
No, not really. I've always been someone that like really enjoyed traveling and just making the most out of things. So it kind of just kicked it up to the next notch. Like, okay, well now, yeah, I might as well. Like everything happened so quickly, so it wasn't really a before or after. Like I didn't even know what was going on. So it was there wasn't like a big difference, but
because I haven't heard very often an emergency sort of removal of a growth. Normally it's discovered, there's tests, then would you mind sharing why it was an emergency?
Because they rang me on a Friday and said we need to operate tomorrow because you're either going to go blind or something in the next couple of days. So I was like, okay. Why? Oh no, because you have a brain tumor. I'm like, yeah, okay. I'll come right away, no problem. Like,
can I ask how old you are?
30. So yeah.
And do you know how big it was?
About between 4 and 5 centimeters.
Okay, so it's quite a big one.
Yeah.
I don't know if
everyone said your 30s, this is going to be your year. So that didn't happen yet, but
I tell you though, the 30s are the best decade. I can promise you're gonna love it. 30s are amazing.
Yeah.
Sounds like it was optic nerve compression, wasn't it? That was the problem. It was. And 30 years old. Probably, have you had your genetics done? That's probably something that's worth screening as well.
Yeah, they said it was like not genetics. That it was just bad luck. Really.
They sent them, did they?
I'm not entirely sure about that.
Big tumor in someone your age, I would definitely send all the genes.
Okay.
I don't know if anyone has heard Lauren Bates's story. So Lauren is a bit of a famous acromegaly almost in the UK. She was diagnosed around 18 and she had a 7-centimeter tumor.
Oh my goodness.
It was huge. And I'm sure she wouldn't mind me saying this. She's completely lost her left eye, taken out. So, the poor thing has had to go through so much. But that's why she's episode 1 on Acro Tales, because if you ever want any inspiration, listen to that story, because it's like, I'm not saying it's like nothing happened, but she has completely accepted it. Life is life. I'm just getting on with it. And it's massively inspirational, I think. So definitely, and Mike's as well, and everyone else's. But that's a very special one, I think. And actually, when I ran the very first Acromegaly meetup, which we did in Birmingham, I think it was 2017 or 18, Lauren had just been diagnosed, and so she had come to this for the first time, and she stood up and told her story, and most of the room there was probably in their 40s, 50s, and I think everyone was in shock a little bit about how serious it was. So fair play to the girl. She's been through a lot. I'm very conscious it's 8:30, Megan. So, and I think the Q&A has wound up a bit, but thank you everybody for your contributions. It was fantastic. And I think you really asked some very, very good questions and made some good observations. And I think we'll say a huge thanks to Rob as well for his insights and input. And honestly, one of the best presentations I've seen that covered technical data without making me want to go to sleep. So really, really well done.
Yeah, thank you so much for wrapping it up bang on time, Dan, as well. I'm very impressed. I've just got a little closing thing to do, but basically just to say thank you to both Rob and Dan for such a brilliant session, for all of your insight and experience. It is so helpful for people, and it's so great to bring everyone together. So yeah, and thank you to everyone for tuning in and for taking the time to join us and ask all of your questions. So like I said before, all of our sessions throughout Awareness Month are going to be available to watch on YouTube and on our website, say mid-November, depending on how long it takes me to edit them all. In the meantime, please feel free to head over to our social media channels and to our website to see the other sessions still available, as well as more resources. So that is just www.pituitary.org.uk. And we are really proud to be able to bring you this session as part of an entire month's worth of informative workshops and online sessions for free. But I do have to do a little plug, as we do rely heavily on the really kind donations of supporters. So if you did find this session useful and are able to do so, please do consider donating to the Pituitary Foundation. You can do this either on our website or by texting LivingWell10 to 785 to donate £10. A text costs £10 plus one standard network rate. And don't forget to check out the rest of our Awareness Month programme. We are nearly at the end, but there are still lots of really good informative sessions coming up. So you can buy tickets or have a look at the programme on our website, but also from buytickets.at/the Pituitary Foundation. And that's everything from me. I'm done talking now. So everyone can go and enjoy the rest of their evenings. Once again, thank you so much to Rob and Dan for such a brilliant session.
Perfect. Thank you, everybody.
Thank you.
Thank you all. See you again. Bye.